the founding principles of the NHS are, of course, free healthcare for everyone. But some doctors are saying that the service is on its knees and waiting lists topping 7 million. Maybe it's time for a bit of a rethink.
NHS directors in Scotland have reportedly discussed the creation of a two-tier system where those who pay, or those who can afford to pay, and those who can't, don't.
So, joining us now is GP Dr Anita Raja, who thinks that if you can afford to pay, then you should, and Dr Emeka Okoricha, who thinks that actually we're fine the way we are. So let's come to you. How would this work? Would, for example, anybody earning over £100,000 a year, for example, when they went to the GP, be given a bill before they left and maybe pay 60 quid for the appointment? If they had a consultant's appointment at hospital, would at the end they be given a chit and go to reception and have to pay £250 for the consultancy? Is that how it would work?
Richard, I don't think that that's going to work. It's going to be a complete mess if we go down that line. Because what we've got to understand is that we cannot hound people to and bill them and get the money for their services. And the idea of the NHS was always that it should be free at the point of service.
Right.
But if we look at different models all around the world, especially Germany, it's a completely different model. The model is that there should be a separate fund towards the healthcare system, not just the NI contributions. So there should be a separate fund and it should be deducted at source.
So tax? Well, a special health tax?
A special health tax.
That is national insurance.
Yeah, but the national insurance doesn't just pay for social care and healthcare. It's your NHS pensions as well. And we now know that the NHS does need more money. We're in a £1 billion deficit. We have established that the government is not happy to fund it or not able to fund it any longer because it's got other priorities. I mean, the priorities are bounce back loans, all sorts of different businesses, supporting other businesses. And the healthcare system is now sinking. So who can help us? Maybe some members of the public who are a bit more affluent. But the question really is, who do we classify as wealthy? What is
So
wealthy?
I was going to ask you, where's the threshold?
Yes, where's the threshold? So is the threshold someone who's perhaps making a bit more than basic pay, something around £50,000 per annum, living in London, still not able to support independent living because they've got a family? Or is it someone who's making millions of pounds per annum? You know, we've got to first of all define wealthy.
So hang on. So where would you? So you want a specific tax purely for NHS treatment, and you want that to go on wealthier patients or across the whole board? But at what
according
point?
According to your
need,
earnings.
according to your earnings.
Yes.
But it wouldn't entitle you to special treatment. You
Never.
You wouldn't
No.
buy
Where
you...
would that be? Would it be
At source.
Yes,
So
but at what salary range?
Yeah, so this is something that the government needs to sit and decide. You see, this is where we need to be careful.
But what's your idea?
My idea is someone perhaps more than 100,000 a year.
On six figures or more?
Definitely.
Okay.
All right, Dr Emeka, you are at the sharp end of the NHS. You're an A&E doctor.
Correct.
You know day to day what it is like for patients having to wait hours and hours for treatment. Surely, if some people paid a little bit more, that would help you do your job
Well,
better.
the thing about it is, obviously, we know that the NHS needs work. We know that it needs funding. However, as an emergency doctor, I just couldn't be in a position where I was under the impression that I was treating patients slightly differently based on what they were earning. Because you have to think of, health economics, what you're under pressure from management to meet a number of quotas, times, and then it comes to investigations. In A&E, we know that some investigations cost more than others. Am I going to potentially order you an MRI scan because I know you can afford it? And because I know you can't, maybe I'm thinking, actually, you don't need an MRI scan. Maybe we can get you an ultrasound the next week.
You're
you don't want
talking
to be in that
about
position.
specifically paying per treatment.
Yes.
But what Dr Raja is talking about is that those earning a little bit more pay a little bit more into a tax. So you wouldn't know when you're treating them
But
whether
aren't they already doing
paid
that?
more or not.
Because you know that the people who are earning more pay a bigger
income tax.
percentage of tax, the income
national
tax,
insurance.
which goes towards the NHS already. So you're almost punishing people for earning more and doing better, which is not going to incentivize people to even want to say how much they're earning because they know they're going to be punished for it under the care of the NHS.
can I ask you this?
Is that
I mean,
fair?
As Susanna said, you're at the sharp end of the
Yeah.
NHS, but you're inside this monolithic machine, this extraordinary, complicated structure, which again and again and again we're told is in desperate need of reform and structural financial reform. Do you think, from your perspective, that that's the case? It needs a root and branch reform?
Honestly, I do think it does. I think every year we go through the same process where we talk about winter pressures, we talk about waiting times, we talk about ambulances being called out and how they're taking longer to see patients, and then patients are suffering with outpatient appointments. And where we suffer is the A&E. If you can't get a hip replacement, you can't see your outpatient doctor, you can't get a routine appointment with your GP, what are you going to do? You're going to come for the 24-hour system where you know you're going to see a doctor.
Well, my point really was, if as a higher earner, I was paying a particular tax, I would be very concerned that actually it was just going into the structure of the NHS and not into treatments.
Exactly. It may not affect your healthcare personally. And who's to say that these people who aren't earning more don't have the option already to go into private healthcare? We know that private healthcare is a thing in England, and it's growing. And so those with money are choosing to opt for private healthcare rather than the NHS.
Dr. Raja, that's the point, is those earning over 100,000, like the Prime Minister, for instance, those of better means are already paying that extra. They're paying private healthcare subscriptions.
That is certainly true, and they're doing that because they want to take the pressure off the NHS, and of course they want better service, quicker service. If I were to tell my German counterparts, colleagues working in Germany, that for a hip replacement I have to tell my patient to wait 2 years, they'd be absolutely appalled. It's embarrassing to work in a system where we have to tell our patients, hold on a minute, you're having an epileptic fit, but you can wait 1.5 years to see your neurologist. I mean, can you imagine how we feel as clinicians?
No, I can see that,
you know, we are exhausted, and you see, it's absolutely outside our remit. Now, we certainly need a better plan.
OK, thank you both very much indeed for coming.
Oh, and also thank you for your work.
Yeah, thank you.
Honestly, I mean, you know, every single member of NHS staff completely valued, and I know all of this sometimes looks like criticisms of the NHS, but, you know, what you do, thank goodness.
Thank you very much.
Well, we have to talk about it, and we have to talk about how it's
certainly.
funded.
Thank
we
you.
could talk for hours about it.
Yeah, I know.
Trust me, we could. But we can't, because it's 7:40.
Waiting in an NHS waiting room.
You'll have hours.
Dr. Reid,
7:40.
thank you.
And we have to move on.